My dear friends and my dear subscribers, today I am here for medical students who are doing a UG or PG. Today I am here to take one of the very important case that you get during your practical examination, and that is the case of obstructive jaundice. I will tell you a few very important tips what you should say to your examiner while presenting the case, because every case has got some hit points. If you forget or don't mention that hit points, it will leave a very negative impact. So today I will tell you how you should present yourself and present the case of obstructive jaundice. Now, before going into the case of obstructive jaundice, I would like to tell you why exactly this obstructive jaundice is. You all know this is the liver. This is the liver. This is intrahepatic biliary radicals. Intrahepatic biliary radicals. These are left and right hepatic duct. This is common hepatic duct. This is common bile duct. This is cystic duct. This is ampulla of water, and this is pancreas. Now we all know that when there is a degradation of the hemoglobin, the heme separates from the globin. From the heme, it forms biliverdin. It comes to the liver to form bilirubin, which is unconjugated. Now it gets conjugated with the gluconuric acid and forms the conjugated bile. This conjugated bile from here, it travels. Some part of it go to the and stored in the gallbladder. Some part through the CBD. It's secreted in the second part of the duodenum through ampulla of water. Now this is the area which is responsible for the obstructive jaundice. So anything which is obstructing this tract will lead to the obstructive jaundice. And the various causes that can lead to the obstruction of the tract is, when it comes to the CBD, it's called CBD stones or cholelithiasis, CBD stricture. Then there is a liver fluke. Then there is sclerosing cholangitis. Then if there is gallbladder carcinoma, and then if there is carcinoma head of the pancreas, or the carcinoma that is involving the periampullary region, this is the most common condition that leads to the obstructive jaundice. Now, while presenting the case of obstructive jaundice, what important things you have to take care? First, you have to tell that this is not a medical jaundice, this is the surgical jaundice. Then you have to say what can be the probable cause of this obstructive jaundice, what is the present status of this obstructive jaundice, and if it is neglected, what it can cause. This thing you have to cover in history of present illness. So let's begin with the presentation of case of the obstructive jaundice. The case you have to present like this. Sir, name of my patient is Ramesh. He is 25-year-old male resident of Delhi. He is educated, he is studying in class 10. He was admitted in this hospital on 8th of June, and I am examining the patient today, that is 10th of June. But this is, then what can be the chief complaint? The chief complaint of the patient is yellowish discoloration of the sclera and yellowish discoloration of the urine since last 6 months, and anorexia and loss of weight since last 4 months. So these are the presenting complaint of the patient. Now, how to present the history of present illness. So my patient was apparently well 6 months back when he noticed a yellowish discoloration of his sclera. It was insidious in onset and progressive in nature. He is saying that the concentration or the yellowish discoloration is increasing, and at no time this yellowish discoloration decreased. So here you have to say whether there is any waxing or waning is there or not. So at no no time this yellowish discoloration has decreased. Now why it can't be medical jaundice? So it said that the patient does not give any history of any prodromal syndrome or does not give any history of transfusion, blood transfusion in the near future. So this will tell that this is more towards the obstructive jaundice. Now what else you can satisfy the obstructive jaundice? The patient does not give does or does not give a history of clay colored urine. Patient gives a history of pruritus. He says that he feels like itching, and his itch increases during the night time, or his sleep is disturbed because of this itching. Now there is any waxing or waning is there or not. So you say that there is no history of any decrease in the intensity of the jaundice during the last 6 months. Then there is no now not other negative history. There is no history of melena. There is no history of hematemesis. There is no history of hemoptysis. There is no history of bowel or bladder disturbance. So there is no history of passing clay colored urine, because if it is there, this goes more in the favor of obstructive jaundice. So there is no history of there is no history of fever. If it is the cholangitis, then patient can have fever. The cholangitis presents with a 3 symptom that is called Charcot's triad. What is it contains? The pain, fever with chills and vomiting. This is called Charcot's triad. There is when Raynaud's pentad also, where this one more symptom is added, that is the mental confusion. So this is just to tell you. Now to proceed with the case, you would like to tell whether if it's a long-term disease, the patient is having any sign and symptom of liver failure. You can mention it here. The history does not suggestive of any sign or symptom that correlates with the patient having the liver failure. Then second complaint, patient says there is history of anorexia. Patient says that earlier he used to eat 6 chapatis per day. Now he is eating only 2 chapatis. Now the second is the patient says that there is a history of loss of weight. Now if the patient has measured, you can say the patient 6 months back his weight was this, now his weight was this. But if not, then how you can justify it. The patient gives a history of loosening of the clothes, and patient says that his relatives or close relatives who reside along with the patient says that he is losing his weight. Then what is significant loss of weight? If the patient loses 10% of the weight in last 6 months, this is significant loss, or 5% of the weight in last 1 month, this is a significant loss of the weight. So all these things you have to mention in history of present illness. Now you proceed further. Past history, the patient does not give any history of hypertension, diabetes mellitus or COPD. Then you go to the personal history. The patient is vegetarian, he is non-smoker, he is non-alcoholic, he is non-tobacco chewer. Then you come to the family history. There is no history of similar complaint in the family. Might be it is because of the medical thing, or might be there is the patient family, they're taking contaminated water and all. There is hepatitis C or hepatitis E is there that can or hepatitis E and A that can transmit through the contaminated water. So in that case history becomes significant. Now you come to the general physical examination. Sir, my patient is 25-year-old gentleman. He is well oriented to time, place and person. He is lying comfortably over the bed. He is moderately built and he is moderately built and poorly nourished. The patient has lost the weight. Built is what is stature of the patient. Nourishment is his nutritional status that you have to person. One more thing you can mention: the patient Karnofsky scale is 90%. What is Karnofsky scale? How much time the patient is lying on the bed and how much time the patient is active. Might be in some of the cases the patients are not well, but they can maintain their work, so they have a high Karnofsky status. Then BP of the patient is 120 by 80 millimeters of mercury. Then pulse is 72 per minute, measured on the right radial. It is non-collapsing, non-bonding. Then CVS S1 S2 is heard normally. RS bilateral air entry is normal. Then CNS is normal. This is the way you can present the history. Now you come to the main part, that is inspection. Inspection, what you have to mention, and sorry, in general physical examination, as this patient is having jaundice, you have to say, you have described it, that I have taken the patient to the bright side light, and I have looked for the jaundice in the eyes or the sclera and palpebral conjunctiva, and I could see the yellowish discoloration. This is very important thing that you have to say in the general physical examination, and how you have seen. The question will be asked, where else you can look for the jaundice. Then you will say, I will look at the floor of the tongue or the palate. Then I will look at the hands, the palms, sole, or the body. These are the places where you can look for the jaundice. As this patient is having yellowish discoloration, you have to mention how you have seen and how you have looked for the yellowish discoloration in general physical examination. Then what else you can see in the general physical examination? Whether any scratch mark is there. How is the nail? The patient who scratch every time, his nails will be shiny. So the scratch mark is there, that you have to also look in the general physical examination. So these two things you should definitely look in the patient of obstructive jaundice, whether the patient is having sclera, or we say jaundice in the sclera, or the patient is having the scratch marks are there. Then you come to the inspection. What exactly you want to inspect? You want to inspect the abdomen to look for whether you can feel or for any lump in the abdomen. That you have to see. So to describe the inspection, before going describing inspection, you must say, sir, I have taken consent of the patient. I have very well explained to the patient what I am going to do, and if it is a female patient, then I have made sure that one female attendant was with me. I have maintained the privacy and secrecy of the patient, and I have taken well informed consent from the patient. Then I have proceeded for the inspection. So in inspection of the abdomen, so this is our area, main area, where we look for. So on inspection, the abdomen is normal in shape. All the quadrants are moving equally with respiration. There is no visible peristalsis, no visible pulsations. There is there's a scratch mark. Of scratch marks you can see over the abdomen. There are few linea gravidarum, what you see over the flanks and all. Then status of the umbilicus, where the umbilicus is centrally positioned. So umbilicus can be shifted up if the patient is having ascites, or it can be shifted down. So if the patient is having ascites and all, in that case it will be everted. So this thing you have to mention in the inspection. Along with you look for the hernial orifice. Now in the inspection itself, where the impulse and coughing is there not, you can say bilateral hernial orifice seems to be what is normal. Then you go for the palpation. On palpation, first thing you say, I look for the local, there is no local rise of temperature. There is a mild tenderness, what I could feel when I press over the right hypochondrial region. So this is one of the positive findings. The mild tenderness was there when I felt over the right hypochondrial region. Then then what else you have see, whether there is no organomegaly, whether it is a hepatomegaly or splenomegaly. In my case, there was no organomegaly, and the gallbladder was also not palpable. In the case the gallbladder is palpable, then how you have to describe the palpable gallbladder? Say this gallbladder is enlarged. Now how to describe the gallbladder? I could feel a lump over the right hypochondrial region, which is about 10 into 8 centimeter. It is globular in shape, smooth and firm. I could feel medial, lateral and lower border. I could not insinuate my finger between the lump and the lever. So means you are not able to demarcate. This thing is attached to the lever. Then this lump is moving or not. Now how you see, you hold the lump like this and see whether it is moving there is any movement is there or not, this movement in the vertical direction, and to tell whether this lump is moving with the respiration. It's very important thing. How to demonstrate the lump is moving with the respiration? Ask the patient to, the patient is lying down, you ask the patient to flex his knees, then you feel for the lump. If say you, for this is the lower part of the lump, you go 2 finger beneath, then ask the patient to take deep breath. In that case, when the patient take deep breath, this lump will come and touch. Normally what mistake you do, you put your finger here also, here only. This is not way to demonstrate the moving with respiration. To demonstrate the moving with respiration, you have to feel for the lower border and go 2 finger beneath, then ask the patient to take deep breath and say whether it is coming and touching or not. Then what is the lie of the lump? Lump can be intraperitoneal or retroperitoneal. This you can demonstrate by knee elbow position. Put in the position in knee elbow position. If the lumps fall forward, it is intraperitoneal. If it does not, then it is a retroperitoneal organ. So this thing you have to take care, and this is how you demonstrate the gallbladder mass or gallbladder lump. If it is there, in my case it was there, but if you feel the lump, you can say that there is gallbladder is that palpable. Then you have to say whether there is any shifting dullness or fluid thrill is there or not. Now to look for the shifting dullness, you have to focus from the top and see where the dullness start. Then you go at one side, see where the dullness is there till what. Then ask the patient to shift to the lateral position so that all the fluids flows to the other side. Now this area will be empty. Now you will have the resonant node over here, which was dull earlier because of the fluid. So this is called the shifting dullness. I'll just repeat it. You percuss from here, go to this extent. The percuss from here, go to this extent till you will be having the dull node. Ask the patient to shift laterally. Then this area will be empty with the fluid. Now you will have the resonant node. This is way how you can say there is a shifting dullness is there. So if there is carcinoma case or ascites there, then you will be having shifting dullness. In our case, there is no ascites, so no shifting dullness was there. Now, now you come for the percussion. Percussion you have to feel for the extent of the lever. Now to feel for the extent of the lever, you have to measure its upper border and the lower border. For the upper border, from the, you say from the fourth intercostal space in the mid-clavicular line or the mid-axillary line, you go start percussing and say and see where the dullness start and see where this dullness ends. And from below, you have to percuss from lower and see till what level the lever dullness you can feel. Then so this will be the span of the lever. You said this is the what is normal span of the lever in the ultrasound. It should be below 15 centimeters. That is span of the lever. Normally lever is not palpable beside the younger ones who have got 1 or 2 centimeter, children who have got 1 or 2 centimeter lever extension. So this is how you demonstrate the examination in case of the obstructive jaundice. Now what how you have to look now, what is the impression? You can say now if the gallbladder is enlarged, then you must remember the Courvoisier's law. Courvoisier's law. What is Courvoisier's law? In the case of obstructive jaundice, if the gallbladder is palpable, then it cannot be due to the gallstone. It is most likely to be due to the periampullary carcinoma. So this is Courvoisier's law, because had it been because of the obstructive jaundice, because of the chronic cholecystitis, there would have been the shrinkage of the gallbladder. But if the obstructive jaundice patient, the gallbladder is large or palpable, then it is mostly due to the periampullary carcinoma. Now this is Courvoisier's law that will be asked to you during the examination. Then the question will go, what are the various causes of obstructive jaundice? You can say the choledochoric, I already told that there can be choledocholithiasis, there can be CBD stricture, there can be sclerorangic cholangitis, there can be liver fluke that obstruct the passage. Then there can be the gallbladder mass which obstruct the CBD. There can be periampullary carcinoma because of the periportal lymph node enlargement. They compress over the CBD. There can be the choledochal cyst can be there. can be the cause of the obstructing jaundice. So how you have to rule out these different cause of the obstructive jaundice, this you will have to tell to your examiner. Now how you will proceed for the patient? First, I would like to do the blood investigation and look for the LFT. What is the serum bilirubin total, direct, indirect, SGOT, SGPT, albumin level, or I would like to do. Then I would look at all the basic investigations: CBC, RBS, urea, creatinine, X-ray, ECG, all the basic tests. Then for particular, I would go for the ultrasonography of the abdomen to look for the status. If I suspect any lymph node enlargement or the periambilic carcinoma, such sort of thing, I will go for the CCT of the abdomen. If the obstructive jaundice is not because of the periambilic carcinoma, just because of the CBD obstruction in some way, and if it is more than 10 milligram per deciliter jaundice, then ideally you should go for ERCP, or else if it is less than 10, you can go for MRCP. So because while doing ERCP, you can do some intervention also, like stenting, or you can do papillotomy. This is then various questions related to obstructive jaundice, related to sign of the liver failure, that will be asked to you. But if you have mentioned this in this way and mentioned these particular hit points, I make you sure nobody is going to fail you, and then rest depends upon to what level you can take to your examiner. One more thing I would like to tell you over here: if you know something, then only you mention it, your history present illness. Otherwise, try to escape it, because if you have told something and you don't know answer to it, then it will be very difficult for you to explain it. Hope I have added some more knowledge about the obstructive jaundice to you people, and you people will be now more comfortable in presenting the case of obstructive jaundice. I wish all of you a very good luck, and request all of you to please subscribe my channel. I will come with various case presentation and various important information about the surgery or about all the medical fields. Thank you. Thanks a lot. Thank you very much.